Good evening, everybody. This is Michael Lee of Johns Hopkins University School for Advanced International Studies in Bologna in Italy. I'm at present in Brussels, and I'm very happy this evening to welcome our guest, Debarati Guha-Sapir, who is joining us for a discussion about the subject that preoccupies so many of us, the pandemic, and the response to it, both in Europe and around the world. We're also going to be touching on broader questions about how pandemics have been fought in the past and what lessons we should take away from our different experiences. You've all received in the invitation the curriculum vitae of our guest, so I'll just say a few words by way of introduction. She is director of the Center for Research on the Epidemiology of Disasters and a professor at the University of Louvain School of Public Health in Brussels and member of the Royal Academy of Medicine in Belgium. She founded MDAT, the International Reference Database on Natural Disasters. She was trained at Calcutta University and at our very own Johns Hopkins University in Baltimore, as well as the University of Louvain in Belgium. And she has a PhD in epidemiology, which I can never pronounce properly. We're all amateur epidemiologists these days, and it would help if we could pronounce it correctly, I'm sure. You can tell we're newcomers by our pronunciation. Anyway, the floor is yours, Debbie. And after your introduction, we have a student panel with 4 students from SAIS Europe here who have a number of questions they'd like to pose to you, and then we'll open up the discussion to all other participants. The floor is yours. Welcome.
So thank you, Michael. Good evening, everybody, and thank you for coming. So Michael explained very briefly my background, and I will tell you a little more about it shortly. But when he asked me to come and speak in the seminar, I said yes, because it was Michael who asked. And I said yes, without actually even looking at the title of the seminar. So after I had said yes and committed myself to it, I looked at what he was asking me to speak, and it was on the European and global response to COVID-19. That in itself is a relatively frightening scope of subject. And I looked at it and I thought, I mean, am I up to the task of taking on this very, very big piece biting off this very big piece, where the potential for misleading, misguided, or flatly wrong statements abound. So I would ask you to bear with me. I will share with you what I have found over time, over like, I don't know what, just over 12 months, not even. December 19th, I think, was the first case in Wuhan. The kinds of things that we have learned over time, or, what we have observed to be, weaknesses in the chain of the control of pandemics, and what we had learned from, say, our experiences from Ebola or Zika or H1N1 previously. So I'll make some comments on it, and we can discuss this, over the time that we have available. To see whether or not, what are what is the real weight behind what I'm saying, whether or not it sounds reasonable. So my background is epidemiology, and over several years I've learned to pronounce it properly. But so the epidemiology part of it actually is, in my case, in my career, applies to health emergencies. So in a way, it is very much related to COVID, but not centrally, because the health emergencies that I work in is mostly humanitarian emergencies. So I work mostly in situations of civil conflict, mass displacement, refugees, where, very large numbers of people move from one place to the other, such as the Rohingya Muslims in Bangladesh. There are about 1 million of those there, in the refugees there, or rather big countries which are completely engulfed in conflict, like Afghanistan or South Sudan, but also in natural disasters. So big ecological and environmental catastrophes. Epidemiology itself, just a couple of lines on epidemiology. What does epidemiologists do, or what does the field actually cover? The field covers the study of transmission of disease, essentially. So what does it mean, transmission of disease? It's a very relevant area in the current situation, transmission of disease. Epidemiologists study the risk factors that make you uniquely susceptible to a illness. So in other words, they try to find out what makes you different from another person when both of you are exposed to the same virus or the same bacteria. So if all of us were in the same room and one person or two persons in that room had a cold, some people were going to get the cold and some people were not going to get the cold. And the question then is, why do some people get ill, whether or not they get infected, and then they actually get ill, because you can be infected without getting ill, as you know now, and some people don't. So that is essentially an epidemiologist's job. So moving on to the center of this seminar, the main point, the reason I'm here, is the European and the global response now to COVID-19. It's true that COVID-19 is a very unique phenomenon in the sense that there have been other pandemics in the past. Certainly the one that people talk about is the Spanish flu, but remember, the Spanish flu came in before penicillin or any of the antibiotics were in the market. So it was really a very different situation. And I would even say it would be a slightly spurious comparison because the conditions were so very different. But still, there are things to be learned from it. And then there were several other big pandemics. And the more recent ones, which are interesting, is of course the H1N1 and the SARS. I don't know whether anybody over here remembers the SARS epidemic. And those were real pandemics in the sense that the disease was carried across the borders and into different places, and it became, and there were susceptible people in all those different places, and it became a worldwide phenomenon. One of the interesting things that's common to the H1N1 pandemic and the COVID-19 pandemic is the problem of vaccine, and any treatment for H1N1 faced a very similar issue that the world is facing now, mostly European Union is facing now, in terms of distribution of vaccines and sharing of vaccines. I don't know whether any of you remember, there was a drug called, a pharmaceutical product called Tamiflu. And there was this very odd story at that time. I can't remember it really well, but maybe Michael will. There was an odd story where, I don't know about the European Commission, but I know that the World Bank stocked Tamiflu by the hundreds of doses in their basement, because the World Bank functionaries were considered absolutely imperative to be protected from H1N1, and they stockpiled it. So this idea of stockpiling bits of vaccines or treatments is not a new thing. This scrabble for who's going to get what and from where, and do you have the money for it, or are you important enough, and so on and so forth. It's not a new phenomenon. That doesn't mean that the European Union, in my view, should get into this kind of protectionism kind of thinking, but that's another story. So this is not a new issue. To start with the European Union, The European Union, as many of you probably know better than I, because I'm not an institutional, I don't study institutions and stuff, but they have put together something called Team Europe. I don't know whether any of it's very recent. It's a Team Europe. It's a new thing. I'm not exactly 100% sure what exactly it is. It's another organ of the European Union, I suppose, and it's Team Europe. And Team Europe has put forward a funding of something like 38 or 39. Some of you will probably know this better than I do. 38 billion euros for the global pandemic control. And this 38 billion is a fair amount of money. I don't know whether it's a lot of money, but it's a fair amount of money. And it has been sort of distributed, and the distribution that I have seen doesn't quite add up to 38 billion, but it gives you an idea of how it's been distributed. So there are 4 areas to which they have identified as priority areas, in the sense geographic areas. And there's about 7 billion for Africa, about 800 million, which is a small amount, but still, I mean, those countries for ASEAN countries, so not South Asia, ASEAN countries. Then 3 or 4 billion for the Western Balkans, not all of the Balkans, but for the Western Balkans, and some 2-3 billion for the EU neighborhood. Now, on what basis this has been done, or whether it has been done on a base of risk assessment for controlling the global transmission or not, I don't know. But this is the kind of distribution they have now for the Team Europe, which is specifically aimed at controlling the pandemic. The kinds of words they use has been a little bit concerning for me, because when this amount of money is put on the table, it's often described as reallocation or reorientation. Now, in my simple mind, and I'm sure that it probably has some other more complex explanations, but when I see the words reallocation and reorientation, for me, it seems that it's essentially moving chunks of money from one budget line to another budget line. So in other words, it's not new money. It's not new funds. This is a very important factor. It's not new funds. So something else is getting cut, which was in the budget previously, and is being moving. And I don't think that's a very good way to do it. The other thing that I think is maybe a weakness in this whole the structure of this Team Europe is the vagueness of what exactly it will do. So it's not just vagueness, sorry, I correct myself. It's not just vagueness. It is I would say, this sounds a little harsh, but I want it a little less harsh, a lack of vision or long-term vision, because it is reduced to buying of masks, providing ventilators, supplies, enhance governance, sort of in terms or activities which are extremely, extremely limited for a strategy of global pandemic control. If you want to do global pandemic control, there has to be a completely different vision. It has to be a vision which is much more long-standing, much more persistent, much more holistic, and with a much better ancrage, anchoring into scientific work. This is the way I think. Helping countries to buy masks is not a solution for global pandemic response. This is really, really a very narrow way of thinking. But let me now go to some some interesting ideas that has been put forward by individuals that I have a lot of respect for. One is Dame Sally Davis from Trinity College in Cambridge, Jeremy Farrar, who is now the Director General of Wellcome Trust, probably the most influential and important private foundation in medicine. And another person who actually I hadn't heard of, but that's my own ignorance, is a person called Jim O'Neill from Chatham House. Now, from the private sector, he's not a medical. Sally Davis and Jeremy Farrar are both medics. Now, they have brought out some very interesting ideas, of which one of which is, I think, very pertinent. The pandemic, in a global sense, has really done something very important. It has shown that sectoral silos and institutional silos can be broken. That is how we have got the vaccine in less than 1 year. That is how we've got, by breaking these silos. By breaking the international silos. There's been cooperation between, and BioNTech and Pfizer is a very good example. But these silos have been broken. And I think that is an extremely important lesson to be learned. The second lesson to be learned is that there is a tremendous need and proven potential for new digital and analytical tools. And what could be examples of these digital and analytical tools? And now I'm talking not just of COVID-19. I mean, COVID-19, I think, has opened that door, saying that essentially underlying the fact that we need absolutely new technologies to control pandemics. We need new technologies. And what would be the kind of new technologies we can use? Of course, probably there are two big areas. One is remote sense data, so satellite data, and the other is telecommunications data. So as some of you may have already heard, things like mobility, traffic, telephone traffic, all of those are extremely good predictors of disease transmission. Mobile telephone traffic, it shows you where people are moving. And that's how Ebola, in the most recent outbreak in Ebola in the Eastern DRC, was very well controlled because of this mobile. So the satellite, remote sense data, the better use of remote sense data, it's getting cheaper. Europe, to its eternal credit, has put up something called the Sentinel-2, which provides almost free data. And telecommunications. The second, I have three, I don't know how I'm doing for time. I have 3 points I want to finish with. So remote sense data is one of the technological advances that will be absolutely essential for pandemic control. The second are diagnostics, rapid tests, and surveillance. Diagnostics, rapid tests, and surveillance. These are areas where there has to be a very important infrastructural investment. I mean, for every other sector, we know that infrastructure, public investment in infrastructure, such as roads or markets or I don't know what, stuff like that, are very, very, very important to boost the economy. Well, it's the same thing in health. We need investment in diagnostics, in rapid tests, in surveillance, and also vaccines and laboratories. The third area that we need to focus in on is international public health systems. So far, we have been focusing on national public health systems, on making sure that countries have strong public health systems, good public health data, surveillance. That silo has to be broken, and it has to go into something which is much more regional and eventually maybe even global. And WHO will have a very important role to play in that. So I would like to end my opening remarks by simply saying that I think rather than sort of knee-jerk kind of things, first of all, knee-jerk kind of terminology, you know, oh, we want to support good governance, and we don't, this is not going to get anywhere, you know, it really isn't. You're not going to go into another country or, you know, 15 countries or 84 countries and say that, oh, we want you to do good governance. This is not going to work. The only thing today, the low-hanging fruit today, is technological advancement, technical advancement. We need solutions which are absolutely guaranteed to have results, measurable results, concrete and product related. So yeah, so with that, I would like to leave it at that and then open it up to discussion.
Thanks very much, Debbie. I took good note of those points. Very interesting, particularly your point about the need for technological advancement as a way of addressing the pandemic. And you mentioned a number of fields and also sources that we'll all be able to follow up on. Before turning to the panel, let me take advantage of my position as a moderator to ask you a sort of naive question in a way. But based on your experience of previous pandemics, what could be a reasonable scenario for how the sort of global course of this pandemic over the next few years? I mean, we're focusing principally on Europe. I mean, I'd like to get a feel for how you think it may pan out in Europe. Is this something that's here to stay? Is this something that we just have to adapt to and get used to, as we do with the influenza and so on? Or are we going to see it really disappearing, the number of cases, hospitalizations, deaths, diminishing drastic? What would be a reasonable, or what's a goal to aim for in that respect? And then what about the rest of the world? How long is it going to take before, on the basis of initiatives taken so far, we can hope that we will also see improvements on other continents, which are also important to us, of course, because even though travel is much restricted today, we do live in an interdependent world, and we will in the future. So what would be a reasonable expectation as to the kind of course that this epidemic might take in the years ahead? I know you've brought your crystal ball along this evening.
Right, exactly. It is. I mean, to be quite frank, it's crystal ball gazing. And why is it crystal ball gazing? Because the lifespan of this virus, as far as we know, has been very short. I mean, as I said, the first case was 2019, 2019, December, third week of December. So, you know, I mean, when you think of tuberculosis or, you know, any of those other diseases, we follow them for years. And there are groups of scientists all over the world who study it minutely. And then we find maybe some sort of solution of things. And here, you know, it's very hard to say anything reasonable on this. But what I can tell you, that what I think is going to happen in Europe and in the Western world, I mean, and I include Japan and Australia and South Korea and so on and so forth in it, the OECD countries, the likelihood is that hospitalizations will definitely go down for many reasons. And some of them are simply because the health sector is becoming better at treating, early treatment, and also because one area that we don't touch upon because we are so vaccine, you know, I don't want to use the word obsessed, but, you know, that's all we talk about, vaccines. There is this whole area of treatment that is quietly developing also and on a different chain. And so I think treatment, very simply treatment, is going to improve, and therefore hospitalizations go down. It is possible that it is going to be like a flu-like situation, which will wax and wane over years. It may also be that some of the vaccines or some new vaccine will give, you know, confer some kind of lifelong immunity or a very long immunity. That's also possible. But in any case, the impact that we have seen in Europe is going to, you know, definitely, I think, be under control and well under control. For the rest of the world, it's a strange situation, I think, for the rest of the world. I would offer that there is a strong genetic influence on the way the disease expresses itself in a human body. And it is quite possible. I mean, apart from demographics of the poorer countries, which are very much in favor of low level, low severity illness and so on and so forth, apart from the demographics of it, I think we are going to see some very interesting research results on the genetics of the immune response. Because what is the problem with the disease is that there is an excessive immune response, an uncontrollable immune response of the human organism. That's the problem. That's a problem with many diseases, is the body can't control itself anymore. And it fights the virus so violently that it kills itself in the process. That's essentially what happens. But this immune response, to me, is probably going to find an explanation in genetic differences, honestly. Because if people were going to be dying at the same rate that they've died in Italy, Spain, and Belgium, and so on and so forth, in these countries, in India, and so on and so forth, we would have had people dying, dead bodies on the street. Honestly, we would have dead bodies, which is not the case. So yeah, I think Europe will have a drop in hospitalization. I think treatment will improve. And as far as whether or not it's going to be another flu-like thing or whether we're lifetime, that we have to see.
Very much, Debbie. Could I invite our student panel now to join us? Do turn on your cameras, and I'll call on you to intervene. And when you do, unmute yourselves. And for other participants, as we go forward, if you would like to ask questions, could you please put them into the Q&A? And I'll keep my eye on the Q&A, and I will filter your questions into the conversation as we go forward. Now, Debbie, we have a range of questions covering different areas. We're going to be hopping around to some extent, but let's start with Moritz. And would you first please introduce yourself in a few words and then come to your question?
Good evening, Professor. Thanks for this lecture and introductory remarks. I'm studying in the graduate program in global risk here at SAIS Bologna, originally from Germany, dual national American and German. And since I spent most of my time during this pandemic in Europe, I'd like to focus my question also on the EU's and European nations' response to the pandemic, which I would say has garnered a controversial record so far. And so I'm thinking ahead of this lecture, what strikes me, the pandemic has aggravated the level of risky decision a decision maker would make. Lockdown versus economic mental health, slower vaccine approval versus faster rollout, et cetera, et cetera. They're very complex trade-offs here. And I would be curious, based on your prior experience and the experience from this pandemic, what lessons can political decision makers at the EU and the national level learn on decision-making in times of national crises like this one, in this, such a challenge? And you change in institutional structures?
Moritz, there's a bit of problem, I think, with the Wi-Fi. It's hard to hear you. Maybe turn off your camera for a moment and let's see if the bandwidth would carry your voice better without the image. We're sorry to lose you. Go ahead, Moritz.
Sorry about that. Does it work better now?
It does. We heard of most of what you said, but maybe you just go over again your final remarks there.
Yeah. So, as I said, on the risk trade-offs of any political decision in such a national crisis, what lessons can political decision makers in European nations learn after a year? And on the EU level, does the EU need to change its structures to respond to such crises, given that at times?
Okay, I think we We lost you at the end there, Maurice, but I think we got the drift of your question.
Yeah. Do you want me to respond?
Yes, Debbie, please.
From the bits and pieces that I did get from you, Moritz, for me, but remember, I'm coming from a biased background. For me, the political decision making, I would say about 70 to 80% has to depend on scientific evidence. There is no ifs, ands, and buts. And if for these kinds of pandemics, for something which is so quintessentially biological, physiological, and scientific, quintessentially, this is not a political decision. And illness is not a political decision. The transmission of illness is not a political. The political decisions have to be subservient to scientific evidence. Okay, then the question comes, are we getting the best scientific evidence, or are our decision makers, whoever is your the decision maker in your radar screen, are those decision makers sufficiently responsible and intelligent to have as advisors responsible, respectable, credible scientific individuals or teams? So for me, the basis of political decision making rests on science for this particular problem, maybe not for other things, rests on science. So all this lockdown versus whatever it is, or open up and this and that, it has to be based on evidence. Now, one aspect which I think has been weak, not just in the European countries and broadly, or even in North America, probably not so much in Asia, but for different reasons, the wealthier countries in Asia, for different reasons, is public communication. And I think public communication is the other half of scientific evidence. You have scientific evidence, you have politicians who are clever enough, intelligent enough to draw on that scientific evidence. And then there is this huge chunk of public communication. And that public communication has been absolutely appallingly bad. And the consequence of this appallingly bad public communication has been a catastrophic drop in the trust of the public in governments. So to take an example, this anti-vaccine movement, the anti-vaxxers, this movement is a reflection of the lack of trust in government, lack of trust in state authority. That is what it is when people don't trust the government to give you the right kind of information, and then you don't want the vaccine. And that is also in the chain, if you go upstream, it is because of a lack of frank and effective communication. So those are, for me, the two main areas. Politicians have to depend on science, and public communication has to be, right from the start, well thought out. Mute.
Thanks, Debbie. Would you like to come back on any of that, Moritz?
Well, I think the public communications part particularly is very pertinent. I mean, you sitting in Brussels, would you have any additional thoughts on the EU's response itself, or is that mainly, so in the situation we're in, a national response given the structure of the European Union?
Well, the EU's response has not been spectacularly brilliant at many levels. I mean, at many levels. It's a sad thing. You know why it's sad? I come from a poor country. I'm an Indian. I come from a poor country. I come from a country which is scientifically extremely advanced, but most of the country is very, very poor. So for me, it is particularly sad because Europe is one of the richest economic blocs in the world. with everything within its grasp, institutions and the ability to quickly bring things to action and so on and so forth. And despite all of that, despite having all of these resources, the most resources in the world, this was an appalling show. It was an appalling show. It was an appalling show for the Europeans, for the poor people, the poor people over here, because the people who died, the people who were desperately ill, people who have lost it, all of it was an appalling show. Now, the part of the European Union and the national governments, I think did not, and I don't know enough, did not manage to slot their actions together in any coherent way. Now, you can say that maybe it's a problem from the past. That is that the European Union does not have the muscle power, to bring these countries together, and the countries do not have the trust in the European Union. Neither of this. Which means what? Which means that the European Union could have. Now I'm talking, I'm not a European Union person. I mean, I haven't worked there or anything like that. I would have thought that the best option for them would have been to lower their expectations, to lower the sort of power play, and say, we will provide you with technical support. We will provide you with technical support. We will provide you with all the coordination, effective coordination. I don't mean making a huge room with a lot of television screens, effective coordination. We will provide you with the best guidelines. We will provide you with other technical support, and leave it at that, instead of trying to get into the politics of these of Hungary and I don't know what, Austria and Malta and God knows what. That is a no-win situation, and it has been a no-win. So
thanks, Debbie. Let's move on. Sarah, you've got a question which takes off perhaps from Moritz's point. Why don't you share it with us?
Good evening, everybody. Welcome, Dr. Guha, to SAIS Europe. My question is about
Sarah, just introduce yourself briefly, Sarah, if you would.
Yes. Dr. Guha, I'm an Indian, and I have come to SAIS Europe to study Master of European Public Policy. And I would like to proceed with the question. So you mentioned about European Union's muscle power, and we are talking about the slow vaccination rollout in Europe right now. So do you think if individual member states were given the power to purchase their own vaccines, they could have catered to the wider range of population demographically to provide them with vaccination?
Sarah, no, I think fundamentally the idea was good, because the idea was good. It was a fair and just idea. Why? Because, small, and, I live in a small country in Belgium or in Netherlands, small countries simply have less firepower on a commercial market to obtain vaccines. It's true. That's what would have happened, is that big countries or with big money would have been able to get a much higher priority in the kinds of vaccines, the amounts of vaccines. So in that sense, the European Union is a much, much stronger negotiating bloc. And it is a much more fair way to get the vaccines. And so it was a just and a democratic way to do it. Sure, I think that has to be admitted. But I think perhaps the, mode d'emploi, what is a mode d'emploi?
Uses manual.
Yes, the ability to actually deploy it. So it's one thing to have the policy. Yes, we will do it together. We will get it on the market. If we will get it on the, we will be able to negotiate much better prices, much better quantities if we do it together. That's policy. But after that, the ability to actually roll it out, to deploy it, that's where the whole thing fell apart. And it shouldn't have fallen apart, because everybody knew from the end of August from the end of August last year, 2020, that this vaccine there was going to be a vaccine and that had to be rolled out. But no preparation was done for this rollout from the end of August. So the rollout was a total failure, and the whole baby now gets thrown out with the bathwater.
Yeah, I wonder sometimes, whenever people criticize the rollout of the EU's approach, they always say, but look, what alternative did we have? The alternative was, as Sarah had said, that all the small countries would just fight it out for themselves. Everyone would be against everybody. I wonder a little bit about that. I mean, we've got 4 or 5 large countries which have quite a capacity themselves. We have groups of countries, the Baltics, the Visegrad countries, and so on. It's not inconceivable to me that the larger member states could have conducted this business themselves, and they could perhaps have involved some of the smaller countries, groups close to them, like Germany with the Visegrad countries or what have you. I'm not absolutely convinced that that these are the only 2 alternative ways that it could have gone. And however badly it may be going, the alternative would have been so much worse, which is in a way the drift of comment from Brussels. Maybe they're right, and I can see the risk, but maybe there would have been intermediate solutions too. I don't know, it's just a reflection. Hannah.
Good evening, Dr. Guha. My name is Hannah. I'm studying international affairs here in Bologna, and I'm originally Dutch. And my question, again, is also related to the EU response. You mentioned before that public communication hasn't been that well, and also the EU's response could have been more quick. And I was wondering what you think the EU's response, how it has impacted the EU's image as a soft power when you, for example, compare it to Russian or Chinese soft power.
The image of the EU as a soft power in the world or within Europe? In the world?
In the world, but in however you would interpret that.
Right. I don't think it has helped. Let's just put it. I mean, this has not helped, because soft power has 2 main drivers. One is the media. Right? How does the media represent a situation to the world? How is Europe reflected in Indonesia and in Congo and in Peru? How is it reflected in these countries? In Philippines, how is it reflected? That is not fantastic. It's not fantastic. The media representation of the EU as a soft power is not fantastic in the last 1 year, for many, many reasons, including that's only one of them, including its performance in the vaccine rollout. That has been, you see, that may not be the most important in its essence, but it is the most important in terms of image. That is the most important. That is what, I mean, in India, they are vaccinating 30 million a day. A day. Israel, everybody knows this. Israel did it. I don't know what, they did some fantastic stuff. And this is the kind of media image that is not going to help the soft power. The second thing about the soft power of Europe is what I said earlier on, is unless Europe has a better vision, European Union, I don't mean the countries, unless European Union has a better vision of how it wants to invest its 38 billion. So 38 billion, we're giving 38 billion. It's not a lot of money, but still 38 billion. And most of it has been taken from other budget line. It's not fresh money. This 38 billion, how is it being invested? If that is not being invested in some long-term strategy, in the soft power, what you call soft power, in its influence in the world, in a longer term, it's not buying masks for Côte d'Ivoire, Ivory Coast, that's going to help the soft power. And so to me, I find that the soft power thing has taken a real kick in the face, for these 2 reasons.
if I might add a word, I think that part of that is based on reality, the performance in the EU, as you say. I mean, as of today, 14% only of the population vaccinated is not a very good story. And soft power is really about the attractiveness of our model in the world and the desire of others to emulate it. So, I mean, this is not particularly impressive. But I'd also come back to our earlier discussion about communications, because even when we've got a reasonably good story to tell, somehow we don't manage to tell it. And let's say on exports, I mean, all the headlines are about the EU system of export controls, which sometimes is reported as export bans. But in fact, I don't have the precise number of countries to which we've exported vaccines, but it's something in the 70s. And I think even compared with India, I'm not sure, but I think Europe is either the biggest or one of the biggest, maybe not as big as India in terms of production of vaccines. We don't hear much about that. We don't hear much about the EU being the major contributor to COVAX, the WHO scheme, where the EU just doubled its contribution. Not a huge amount. It's very slow to get off the ground, 1 billion, but okay. So I think it's a mixture of genuine poor performance and very bad communications. Yes. But yeah. You mentioned briefly India a few moments ago, and one of our participants online, Sneha, asks about, his question is, with the rise in vaccine exports from India, how do you see India combating vaccine deficiency at a time of rising cases and the risk of a second wave? So is India's export strategy at the expense of a vaccine campaign within the country?
You know, India, it's going to be a bit of a messy start thing in India. Now, there are two things going on. One is India is a huge producer. You know, the Serum Institute of India, they produce, you know, I don't know, some mad share of vaccines in the world and so on and so forth. They're a huge producer. And they've been exporting already from January, actually, from COVID-19 vaccines. How it's going to play out between the very nationalistic and jingoistic government that we have in India right now, with extremely regressive and very populist policies, the chances or the discussion is already kind of veering towards, we're not going to let any of our vaccines go out of the country. So there is that playing in. The only thing is, I mean, you know, all of you are you sort of experienced political scientists, and you would probably understand this better than I do. I can imagine that the global community does have some leverage over India to stop them from completely blocking the exports. You know, they must be able, in some of the global forums, you know, the different forums that are around of the UN and things, and India has also very big ambitions on where it wants to be in the United. I think there is some play there, some leverage there, but there is definitely murmurings, or more than murmurings, of the current government saying that we are not going to let. But not so with the CEO of Serum Institute. I think the CEO of Serum Institute is a remarkable man. He was on Hard Talk on the BBC not so long ago, young man. And I think he understands very well the importance of keeping a balance between the export and the domestic consumption. Yeah.
Thanks very much, Debbie. Madeline.
Hi, thank you so much for coming to this panel. My name is Madeline. I am an American and I'm in the Global Risk Program in SMART. My question for you is about the World Health Organization. It seems like every day we find out more about the COVID-19 disease, and especially at the beginning that was very true. And there was to some degree, it seems like mixed messaging. You've already talked a bit about the communications issues. So my question is, what would you change about the World Health Organization to COVID-19 at its initial stage, knowing what we know now?
What would I change about the World Health Organization, about the COVID-19? You know, World Health Organization needs a lot of change. It really does. I mean, I don't want to sound like John Bolton, or even much less Trump, actually, not to put too fine a point on it. But it does need a lot of, you see, the problem with WHO is what? I don't want to go into the, into the weeds into this. The organization, as opposed to UNICEF, WHO is governed by ministers of health. That is the General Assembly of WHO, ministers of health. That is an extremely important, and it's one man, one vote. So the Minister of Health of Maldives has the same weight as the Minister of Health of China. So in terms of voting, now that makes it very difficult. It's like, there's a saying, I think it's an American saying even, would turkeys vote for Christmas, right? Would turkeys vote for Christmas? And in the WHO, it's the same thing. What has happened now is that to change anything in WHO from the status quo has become almost an impossible task, because the ministers of health will not vote for anything that changes the status quo. So when you ask me what I would like to see in terms of how to change that, I would say that the WHO needs to have a structural change. This is almost an impossible thing given the such and such. Why is that not the problem with UNICEF? UNICEF doesn't have what is called assessed funds. The UNICEF is a voluntary organization. So people, the countries that give money to UNICEF, it is a voluntary contribution. And this means that in the case of UNICEF, of course, we've been relatively lucky. Most of the funding of UNICEF comes from the Nordic countries. They give huge amounts of money to UNICEF, huge amounts of money, and essentially keeps the whole thing afloat. Not so with WHO. Not so. So what I'm trying to tell you, I'm sorry, Madeline, is that the problem with WHO is structural. And there has to be structural change if you want to do something about WHO. Other than that, WHO has now spawned all these different little initiatives, Gavis and this and that and the other 100. And that is how it works. It's got all these little bulblets around, and that functions, but the structure itself is figé, it's completely paralyzed.
Thank you, that's very interesting.
Madeline, I think you had a question too about how the pandemic is affecting wealth disparities between countries.
Yes, obviously there's very disparate rates of vaccines around the world, and I saw statistics that was something like 86% of existing vaccines are going to wealthier nations, whereas I think 1% are going to poorer nations. Obviously, this is going to cause some impacts in the long run. So I'm just curious what kind of the potential impacts of this disparity will be.
Yeah. The inequalities related to the pandemic will be less related to vaccines than it will be on the cost of loss of livelihood due to the measures against the disease. And it's a very difficult, very ethically challenging discussion. I don't think the vaccines, it is absolutely true that the vaccine, there's a very small number going to the poor countries. You must also know that there are much fewer cases in these countries. The population is young, most of them live outdoors. There are conditions that make the number of cases very low. It is really very low. So I think more people, I wrote a paper. No, it's not a paper. It was a small piece in a journal called Science, right? Science. This is an American journal. And with colleagues, it was not just me, with colleagues. And we spoke about measles. You talk of inequity. What happened last year? Last year, 37 countries, 37 of the poorest countries in the world, were asked to stop the measles campaign, the EPI campaign, the expanded program for immunization, so all the childhood vaccination campaign, in particular measles, stopped the campaigns because of social distancing and the lockdown. Now, you can argue in favor of that. Yes, COVID-19, horror, catastrophe, stop everything. Measles stopped. Result was that 126 million children, small children, within a period of 9 months, were left unvaccinated. What are the implications of that? You can say that, okay, we're going to vaccinate them then later. No, the measles vaccination has the best response, physiological response, if it is given within a certain age range. So the kid has to be vaccinated at certain. So you've missed that age range. You've missed that age range. So now when you go back, if at all you go back, you can imagine that in Mali and Mauritania and Mozambique, I don't think they're going back very soon. So when you go back, you're not going to get the child at the right age anymore. That child is now 2 years old. So that is going to be the problem of inequalities. I don't think the vaccine is the issue. I really don't think vaccine is the issue.
Thanks, Debbie. Sarah, you've been thinking about possible solutions, if that's not an overstatement, to these disparities. Could you share some of your thoughts and your question with us?
Yes, Dr. Guha. So you mentioned about the poor countries here. So of course, with COVID-19, we have seen a huge disparity between the global north and the global south. So do you think if we can engage these global south countries in the global value chain of production of vaccines, so that is going to help them recover economically and as well as boost their public health?
Sarah, you mean if we get them to be able to produce vaccines in their own countries?
Yeah, and engage them in the global chain, meaning that we can also have a factory there and we can break down the product life cycle.
Yes, I think that's a very good idea, and I think it's a very, very reasonable idea, but it depends on the complexity of the production of the vaccines and the sub-products that are used to make that vaccine. You see, a vaccine is made of many, many, many different things, and you have to get a supply chain for those different things. And not everything, not all of the subcomponents are produced in their own country, not even here. So those things have to be supplied. So there is a complexity to development of vaccines. It also means that vaccines typically, many don't. I mean, measles vaccine, for example, is a very good example, that you don't need a very, very, very advanced conditions for their development, for their stockage, to make sure they're not contaminated, all of that, that whole process. And many countries in Asia, it is very much possible. Most Asian countries, it's very much possible. And in many African countries as well, Kenya, Ghana, Nigeria, there are countries which have very good facilities. And I think it's a very good, the thing is the companies have to give up their recipe. Apart from AstraZeneca, I don't know of many other companies who have actually, essentially given the recipe out to other people. You need a license for that.
Sarah, you had a question about that very subject, I think. Would you like to come in now? Hannah, sorry, apologies.
No problem. Yeah, indeed. Yeah. So recently, South Africa and India asked the WTO to waive the IP rights of member states for the COVID-19 vaccines, but that request has been blocked by the UK, the US, and the EU. And I was wondering whether you have any insights on why.
I don't know, patent rights? I mean, money? Is that an option?
No, intellectual property rights.
Yes, but if you give up your intellectual property rights, essentially you give up your what is the word for it? Your patent, the money that you get out of these patents. Royalties, yeah, that's right, royalties. So at the end of the day, it comes down to money, no? No.
Yeah, but also in the whole context of a disparity between developing and developed countries, and in their process of getting vaccinated, the request was up until the point that I think 90% of the world is vaccinated.
So what you're saying is that the WTO has proposed giving up the IP rights to certain vaccines. Is that correct?
No, that South Africa and India have requested to the WTO to do so.
Oh, I see. I see. They've done it before, South Africa and India. They've done it before for the antiretrovirals for AIDS. There's a history. There's a precedent on this. There's a precedent, and I think, if I'm not mistaken, it's India and South Africa who did exactly that. They were the reason antiretrovirals actually have become generic brands and so on and so forth at that time. It took some time. It took 2 years. Was, funnily enough, it was the muscle of Médecins Sans Frontières. Médecins Sans Frontières entered the fight for the antiretrovirals with South Africa, and you see they pulled such a huge popular support that in fact the pharmaceutical companies caved in, the countries caved in. So I don't know how this will play out. I think India, South Africa, if they manage to get further support from, say, the civil society organizations, then you might see a change. You might see a change.
I can see an issue depending on how things roll forward in the years to come. We have a question from Pablo online about what we can expect in the coming years. And given that this is something that's going to be with us for some time, I think that some governments are reflecting on whether we've had a good approach until now. And I know some of the people, for example, who are advising some possible new leaders in Germany and elsewhere, whether to continue with this approach that is based essentially on the private sector, or whether in the future to think more about public-private partnerships to develop vaccines and for other purposes, with much more public money going in. Because really this is something that we haven't done to that extent really in Europe. And it seems to me there could be a sort of link between, how much public money is going in and whether or not patent protection is granted to the companies. And if the public has coughed up, tax dollars or euros to a very large extent, it doesn't quite seem right that the companies would then make large profits from that, even though it's their incentive perhaps for further research. So perhaps in the future, if indeed we see this kind of role of the state or the EU or others cranking up, we might also see a shift in attitude on this question about patent protection. I don't know. You know the sector much better, Debbie. What do you think?
I'm just thinking now of BARDA. Have you heard of BARDA? BARDA in the United States. And the new, I don't know whether, I think the parliament has approved, or there's some process that has been approved of the, I don't know, one of you will know, what is it called? HERA, HERA. So the Europeans, the Americans have the CDC, so the Europeans made the ECDC. And then the Americans have BARDA, and so now the Europeans are starting up this thing called HERA. And HERA stands for Health Emergencies Response Agency. Make another agency. Yes, that's the solution. So they have this HERA, and this is a very important part, actually, of what BARDA does, what you just said, is this private-public partnership. But BARDA has, I think, several $100 billion in its pocket. And I'm not exactly sure how they manage the public-private partnership thing, but that is their job. Their job is to be able to inject money into the development. And that is why, I might be simplifying this a little bit, but that is why, if you look at the history of BioNTech and look at how they evolved, BioNTech did not get the necessary funding in Europe. BioNTech did not get the necessary funding in Europe. It went to BARDA. And BARDA gave it the money. And that's how BioNTech came. Now, it's also true that, there are like, there can be 50 BioNTechs and only, 45 of them will lose. You will not get, but that's pharmaceutical research. So I think this private-public partnership is a very promising avenue, and it needs some thought. But this is the future. This is really the future.
Moritz, I think you're back with a better connection now. Would you like to follow up?
I'll give it a shot. Future is a good keyword on which I can queue up my next question. So evidently, the race for vaccinations in response to the pandemic has really sparked some scientific advances in the field. I mean, the mRNA technology seems to be, based on the limited knowledge I have, a significant breakthrough. So I'd be curious, taking a broader view beyond COVID itself, what scientific advances could this vaccination or race to find a vaccine bring for other health emergencies, other viruses, and responding to those? And on the flip side, are you concerned that we may sort of overshoot and overlook certain ethical considerations when we push these scientific advances so quickly and with such with so much public money and public effort that goes into it?
Right. So the mRNA technology has been around for a while. It's not a new thing. It's been in the works for a while. What is new, I think the most important new thing over here is the incredible rapidity of the process. That the whole process was kind of rammed through, and it brings us to this ethical thing. The whole thing was rammed through in a matter of months, when vaccines normally take years and sometimes decades, 10 years, 15 years before you get a vaccine on the market. So what happened was, obviously, this BioNTech people and the Moderna guys, I mean, they had all this technology already bubbling around, in their laboratories. And then they had this push. The government opened doors and they said, we'll give you the opportunity to make as much as you want, if you can get your trials done, your, phase. None of them even raised that, came to, I think, phase 3 trials, but at least phase 1 and phase 2 trials. And they just, it just boiled over, and you had these things. And the mRNA vaccines, the technology is a very, very good technology, for many reasons. They are not attenuated vaccines like many of the other vaccines. They can be tweaked very easily. It's a matter of, weeks or maybe a month before it's tweaked to fit into some other viral. So it has a lot of potential, and it can deal with a lot of viral diseases. I mean, we do have very good vaccines. For instance, the yellow fever. I don't know whether you've heard of a disease called the yellow fever. And the yellow fever is a viral disease. It's in the same group as Japanese encephalitis, dengue, and so on and so forth. And the yellow fever has a vaccine which is lifetime immunity. Now, so we have some very good ones. These are not mRNA. But mRNA vaccines could be fantastic for some of the big viral diseases, dengue and things, which are now becoming very big. So I think there is a huge potential there, and it is a technology which has been rather simplified. The only problem with this is, the maintenance of the vaccine, which has, conditions. Now, the ethical question, Moritz, I don't know that I can give a interesting answer to that. I don't know, because, the vaccines always have an ethical issue. There is always a probability of the disease. And also what is it called? The economists have a word for it. That you get a kind of a false sense of security. You know, if you have a protection, cholera, for example, the cholera vaccine has a efficacy of 50%. But once you're vaccinated, you think, that's it. I can go and drink all this water from the taps in Bangkok, and you know, I'm going to be fine. Moral hazard, that's right. The economists have, the moral hazard. And I think there is that issue of the moral hazard there. There is the issue now of vaccinations in children, as you may have already read about the COVID-19 vaccine, as an emergency measure. I cannot give you an interesting answer to that. I cannot give you an interesting answer to that. I'm a vaccine pro-vaccine person. So I think the risks of not having a vaccine is far bigger than, on a public health sense, than the risk of having a vaccine. And that's going to be my position, I think, for a very long time.
We've got a question now from Thanos, which as a previous vegetarian, I hesitate to put to you, but nonetheless, Thanos says, what changes do you believe are needed in the meat industry to lower the chance of new zoonotic diseases such as COVID-19 spreading and potentially becoming new pandemics?
Wow. I'm being a vegetarian myself. What are you saying, Michael?
No, I would say you could plead also vegetarianism on an issue like this.
Yes, but I'm not a die-hard vegetarian, but I'm also a great lover of fauna, of animals, and I do think that everybody has a right to live. Everybody has a right to live in the world. Everybody, all living beings. So including spiders, actually. So yes, the meat industry, but the meat industry is not going to go away anytime soon. Not only because the Western countries are very, very meat eating cultures, but also Asian things. They're all meat eating cultures, except for India, who sort of rejoices in vegetarianism. But other than that, very few countries, Africa, very few countries. So meat industry is here to stay. Now, what could be, it's this wet market thing, how do you regulate wet markets and, all this. Remember Nipah, what was that disease from the pigs? Nipah fever from the south of Philippines and things. I don't know, who was it who asked the question?
It was somebody online, one of our students, Thanos. He's not a panelist, so we can't engage with him.
I see.
But he sent in on the Q&A this particular question. I would guess that the question is based on the thought that some epidemics might have begun through the meat industry. Not on this occasion, I don't think. Perhaps there's some indication. We still don't really know what was at the very beginning of this epidemic. But let's say as a broader question, is this a sector that we should be concerned with as a source of various epidemics that we should focus on for research and other purposes?
There is a lot of, the zoonotic, AIDS, for example, the AIDS and Marburg and Ebola. They're all tied to, they're bats and gorillas. The reservoirs of Ebola and Marburg are gorillas and bats. AIDS is green monkeys, right? So there are these jumps between species. Now, whether or not, it's a philosophical question, whoever asked it. It really is a philosophy. Whether or not you can control these jumps from animal species to the human, where they will be pathological, whereas they are not pathological in the animal species. How does one, I can't even imagine how one can control them. What is our main problem? I don't know about COVID, and as I said, as Michael said, the jury is still out on that. But you see, as human habitats are pushing into lands coming into interface between wild habitats. Humans and wild habitats are coming into closer and closer confrontation. That is where the zoonotic leaps occur. That is where the zoonotic. Then you have to start thinking about, land use. You have to think about population growth. All of those, big questions.
So it's an issue much broader than simply the conditions in which meat is processed. It's an ecological question that touches on many issues. That could be a good theme for a thesis, maybe, Thanos, if you're thinking further about that. Madeline, you had a question with a wider historic perspective about what kind of lessons there might be from previous experiences. And while you ask your question, could I ask the panelists if they have any final questions they'd like to ask, as I have my eye on the watch, and Debbie's been very generous with her time, but we're coming to the end of the session. So if any of you have any further follow-up questions, bear them in mind, and I'll come to you after Madeline has posed her question.
You. So you mentioned earlier that Spanish flu is not always the best comparison to this epidemic, that other ones, maybe H1N1, SARS, are. So just keeping them all in mind, I'm just curious about some of the best practices that we've observed in the past when it comes to governments alleviating the socioeconomic effects of the pandemic.
Madeline, you got cut off right in the middle for a bit, and then just give me the question.
Yeah, yes, of course. So based on the H1N1, SARS, and to some degree the Spanish flu, as much as they are comparable to COVID, what are some of the best practices that we've observed by governments in the past when it comes to alleviating the socioeconomic effects of a pandemic?
Spanish flu goes back too far for me to. I mean, a lot of people died, but I know not very much more than you do in terms of what happened then. I must say that offhand, I would say that the socioeconomic impacts of a pandemic has really been pushed out in the front page with COVID. Really pushed out. I come from public health. I have not heard, there's some, but I've not heard a great deal of debate or read scientific literature on the HIV/AIDS pandemic, on the Ebola pandemic, on the H1N1 pandemic. This issue has not been really delved into in any one of those. In COVID-19, it has become the priority number one. And part of the reason why it's become the priority number one is not because of what the disease does to a person, but what the measures to control it has done to people. Now, you can have, people will have their own views, and I don't want to get into that because it's a very delicate a very complex and delicate issue. But the economic impact of COVID-19, which is probably now taking up most of the oxygen, is linked to the measures of containment and not the disease itself. Remember, because most of the people who died were older people. Most of the people who died were older people, which means that I know what I'm saying sounds like, really a bit harsh, but the essentially is that they were 60 or over, right? So their role in the economy was less impactful, whereas the lockdown measures really had an impact on the working population. So it's really, it tilts the whole analysis in one direction.
Thanks very much, Debbie. And before we wrap up, let's just do a little table round of our panel. And see if there are any last thoughts or last questions that you'd like to pose. Hannah.
I actually don't have any questions up to now, but I want to thank you for your time.
Thanks, Hannah. Moritz.
Thank you. I would have one last question. I was wondering, this has been another real life health emergency that you have experienced. Is there any specific lesson that you learned that was new to you and that you thought was really significant for your work coming from this pandemic?
Yeah, I have learned a lesson, and where I was spectacularly wrong all my career. And so suddenly now I have discovered that in fact, global surveillance, now it's going to sound a bit boring, but the truth is I was very much always into, strengthen the local systems. I work on the field, I'm working out in the refugee camps, I'm working out in natural disasters. My view was always strengthen the local structures. Give the power to the local people, they will find a solution, and that's how we are going to get to something. This has been my mantra throughout my whole career. Well, now, and somebody asked this question about WHO before, I don't know, I think it was Sarah. Now I feel that one thing I've learned is that today, in this century, if we don't have a global surveillance system, some sort of global surveillance, whether it's satellite-based data, whether it's mobile communications data, whatever, but global surveillance has become absolutely critical to be able to control any kind of communicable diseases. It cannot just depend on local little kind of, let's get a cultural thing and the villages should do their own thing and say, all that sounds really good, very hippie and very 1968, but really what you need is a global surveillance system. That's what I've learned.
Thanks very much. It's wonderful, isn't it, that we can still learn, Debbie? I find I'm learning something every day, and especially from your presentation. Sarah.
Yes, Professor Lee, I would like to take a question before we wind up. So, Dr. Guha, we all know that you have been associated with the multilateral sector before. So, we're talking about the SDGs here, and each one of us, we are directly or indirectly related to the SDGs, and we are all respecting it. And we have exactly 9 years from today to achieve the goals in 2030. And COVID-19 has added a new dimension to it. So do you think we can still achieve the SDGs in a local structure, international structure by 2030?
And Debbie, before you jump in, Madeline, as time is short, why don't you come in with any last thoughts or questions, and then Debbie can answer both of you together.
Sure. Yeah, I don't have any last questions, but thank you so much for your time, and I learned so much. Thank you.
Thank you. Debbie.
Okay, so SDGs to 2030. Sarah, I don't want to demoralize you about the SDGs, and you're absolutely right. We are all involved in the SDGs. The thing is, SDGs, if you look at them and also the sub elements, they are actually aspirational. This is what I learned from Jeff Sachs, who was the father of MDGs, and I don't know, maybe the father also of SDGs. He seems to have a lot of fathering. And one of the things that he said is these are aspirational. Now, that said, that doesn't answer your question, because what I'm telling you is that SDGs set a goal, and we all try to climb towards that goal, and we may or may not arrive there, but we have to keep trying. That is what I'm telling you. But the COVID-19, I think, in fact, for reasons that I've said before, for the poor countries, I think it has had a tremendous setback to the poor countries. And not only poor countries for the economics of it, people have lost livelihood, but to me, I find that this setback in primary healthcare, in vaccination campaigns, which have all been paralyzed for months on end. this is going to be a huge price we will pay. Huge price.
Well, with that not entirely encouraging thought, let's bring this tremendously interesting session to a conclusion. Thanks so much for being generous with your time and sharing your experience, your wisdom, your learning experiences with us. And thanks to Hannah, Moritz, Madeline, and Sarah for your questions and your involvement. I do hope, Debbie, we'll have an occasion to welcome you in Bologna in person. It's a wonderful place, as I'm sure you're aware. And normally after a session like this, we would all go off together to a pizzeria or to one of Bologna's nice restaurants and spend the rest of the evening chatting together. We can't do that, but I'm sure the time will come. And we hope to welcome you to Bologna then. So many, many thanks, and looking forward to further discussions with you in the future.
Wonderful. Thank you. Thank you very much. Thank you to all of you.
See you all again soon. Thank you. Bye-bye.